right, this is our lecture discussion of the cardiovascular system, part 2, going over the heart. So the heart, like we said, is a muscular pump, and it is made up of 3 layers of tissues. We have the myocardium, which is the muscular layer of the heart, and then we have the endocardium, which is the thin inner lining of the heart that's exposed to the blood. And then we have the pericardium, which is the outer layer of the heart that contains the connective fibrous tissue to hold the heart, or to separate the heart from the rest of the chest cavity. So that's the pericardium. So looking at the heart, we look at the chambers. There's 4 chambers in the heart that are separated by valves. And the top 2 chambers are the atria, and the larger, more muscular chambers below are the ventricles. So in looking at the structures of the heart on page 95 and 96 of your textbook, we have this picture. This is on page 95. So these are the muscular receiving chambers of the heart. These are the atria. So the atria, the right atrium, the left atrium, receive blood into the heart. And then we have the ventricles down below. We have the right ventricle and the left ventricle, and there's a layer of blood, not a layer, but there's a set of blood vessels that runs down the middle here that divides the ventricles. So this is the right ventricle, this is the left ventricle. In this view, it makes the right ventricle look much larger than the left, but that's not actually the case. They're both the same size, they contain the same volume of blood, but the left ventricle is thicker because of where it pumps blood to. So again, we have the right ventricle, left ventricle, right atrium, left atrium. So the atria receive blood into the heart. We can see that there's veins that carry blood to them. So we have the superior vena cava bringing used blood from the upper part of the body, and the inferior vena cava, which brings blood from the lower part of the body into the right atrium. So both of these vessels carry blood into the right atrium. The left atrium has veins coming from the lungs. There's 4 veins that feed the left atrium. We can see the left pulmonary veins here, that leads into the left atrium, and the right pulmonary veins coming from the right lung lead also to the left atrium. So there's 4 vessels that we can see that lead to the left atrium. We can't see them because they connect to the left atrium in the back, so we can't see that entrance point in this particular picture, but we can see those 4 vessels, and they're red because they carry oxygenated blood. So when you look at diagrams, we see red and blue, blue meaning low oxygen levels, red meaning high oxygen levels. But when we look in the actual body, they are the same color. We can't tell the difference in terms of color. They're all the same. So just like the vessels here over the heart, these are the coronary arteries that carry oxygenated blood to the heart muscle, and these are the cardiac veins carrying deoxygenated blood back to the heart to be oxygenated by the lungs. Again, blue and red is only for diagrams and pictures and models of the heart. Blood is never blue. Blood is either red or dark red. Bright red if it's full of oxygen, dark red if it's low in oxygen. And sometimes our skin gets a bluish appearance to it when it's low in oxygen, but that doesn't mean that the blood is blue. There's a myth out there that people say that when the blood hits the air that it turns red. That's not true. Blood is always red, whether it's inside the vessels or outside the vessels. Blue is only used in textbooks and models to indicate low oxygen levels. Typically when you look at the heart, the veins are blue, the arteries are red, but that's not the case with this vein. This is the pulmonary vein. It's bringing blood from the from the lungs to the heart. So this is to be oxygenated again, and then it's pumped from the left ventricle to, oh my gosh, I'm saying this totally wrong. So the veins carry blood to the heart, and they connect to the atria. So we have the superior inferior vena cava that lead to the right atrium, and we have 4 pulmonary veins that lead to the left atrium. We can't see the connecting spot, but these 4 pulmonary veins here, shown in red, lead to the back of the left atrium, and they bring blood to the left atrium. So the atria are the receiving chambers of the heart. They receive blood into the heart from the veins, superior and inferior vena cava for the right atrium, and the 4 pulmonary veins for the left atrium. Then we have the ventricles down below. The ventricles, their job, the right and left ventricle, is to pump blood away from the heart. The right ventricle pumps blood to the lungs, and it has an artery that attaches to it. This is the pulmonary artery. Notice that it branches right and left because it's going to serve each lung. So the pulmonary artery does not have oxygen yet, so that's why it's blue, but it is an artery because it carries blood away from the heart. So the right ventricle pumps blood to the pulmonary artery to the lungs to be oxygenated. And then once it's oxygenated, again, it returns to the heart via the 4 pulmonary veins to the right, via the left atrium. So this is the pulmonary artery from the right ventricle. The other artery that connects to the left ventricle is the aorta. So the left ventricle, when it pumps, it sends blood to the aorta and the rest of the body. This is the largest vessel in the body. It receives all that nicely oxygenated blood ready to go to the whole body. So it has many branches on it as it continues on beyond the heart. So if we look at the inside here, we can see these chambers a little more easily. So here's the left atrium with the 4 pulmonary veins. Remember, this is your patient facing you, lying down on the table or sitting in a chair, so that's why everything looks opposite of what you're seeing. It's not your left and right, it's the patient's left and right. So this is the left atrium, right atrium. Left ventricle, right ventricle. Can you see how thick-walled the left ventricle is? See this muscle here? Just like any muscle, the more we use it, the more force applied, the thicker it gets. So the left ventricle is very muscular because it has to pump its blood up to the aorta and the rest of the body. So if we followed this aorta down, we would see it passes behind the pulmonary artery and attaches here to the left ventricle. So these are the left and right atria. They receive blood into the heart via these veins that attach to them, and then they pump their blood to the ventricles. So there's a valve in between there. This is the right AV valve. This is the left AV valve. Some people call this the tricuspid valve. That's the right AV. And the mitral valve, the left AV valve. So they pump their blood down into the ventricles, and then when the ventricles contract, they pump their blood up through those arteries, the pulmonary artery from the right ventricle and the aorta from the left ventricle. They each have valves at the base of these vessels, and those shut after the blood is pumped into them and starts to flow back. That shuts those valves and prevents backflow. So the valve closing is what causes the heartbeat that we hear when we put a stethoscope over the heart. So let's go back to our notes. So we talked about the valves. We have the AV valves separating the atria from the ventricles. So that's these are the AV valves, and they have these strings attached, so they're easy to distinguish from the pulmonary valve and the aortic valve, which isn't shown in this diagram, but it looks like this. It's at the base of the aorta right before it leaves the ventricle. So the AV valves have these strings attached called chordae tendineae, and they just prevent the flow of blood backwards. They hold these valves in place so we don't have backwards flow. We always want blood to flow through the heart in a forward motion. So the sounds we hear, the lubbed up of the heart, is the lub is the closing of the AV valves when the ventricles contract, and the dup is the closing of the semilunar valves, which are the pulmonary and aortic valves. When those close, that's the dup sound, and that happens when the heart is relaxed, when the ventricles are relaxed and not contracting. So we kind of went through the internal portions of the heart. I talked about the valves using that other picture. So when you look at the sides of the heart, the right side of the heart has blood low in oxygen because it just came back from the body. So if you look at the vessels here, those vena cava that are bringing used blood to the heart, into the atria, then to the right ventricle. This part has deoxygenated blood. So the job of the right ventricle is to pump that deoxygenated blood to the lungs via the pulmonary artery. So blood is low in oxygen on the right side of the heart before it hits the lungs. Once it goes to the lungs and it comes back and it's oxygenated, so the left side of the heart is the oxygenated side. So the left side of the heart is oxygen rich, so it's rich in oxygen, and it pumps blood to the body tissues. So the right side of the heart pumps blood to and from the lungs. The left side of the heart is going to and from the body tissues. So we have this circuit here that kind of includes the lungs and shows us the blood flow. And I have a video animation to show this as well, but you have this nice picture here that in your textbook on page, let's see, right here. This picture is, let's find the page number for you quickly, is on page 102. It kind of shows the flow here. So we have the superior and inferior vena cava leading to the right atrium. That blood flows to the right ventricle. The right ventricle contracts and sends it to the lungs where it picks up oxygen. And those pulmonary veins, again, there's 4 of them. That's only showing 1 here just for simplification, but there's 4 that brings it back to the left atrium, to the left ventricle, and the left ventricle pumps it out the aorta to the rest of the body. So we can see the right side of the heart is blue because it's deoxygenated blood, and the left side of the heart is red because it's oxygenated blood that's already been to the lungs. So I have an animation here to kind of show the blood flow through the heart, and then also the systemic circuits. So the heart is about the size of a fist. So here we can see it beating. The ventricles are contracting. The atria are contracting before the ventricles to make sure the ventricles are completely filled. And we can see that the deoxygenated blood on the right side and the oxygenated blood on the left side. We can see the thicker wall, outer wall of the ventricle. And the dividing wall between the ventricles is called the interventricular septum. Can you see the closing of the valves? Notice how the AV valves close before this is the aortic valve, this is the pulmonary valve. And that contributes to the heartbeat. You can watch this animation separately in our Blackboard folder, and it'll give you the sounds of that lub dup. So the dup is the closing of the pulmonary and aortic valves, and the lub is the closing of the AV valves. So here's the right AV valve. It's got those chordae tendineae attached, and we can see the blood cells flowing through that are deoxygenated. And there's the pulmonary valve. And then we have the left AV valve receiving that oxygenated blood from the veins, the pulmonary veins, and then the aortic valve at the base of the aorta closing as the heart relaxes, and that blood tries to flow backwards, but the valve prevents it. So this is the left ventricle and the right ventricle. You see that the left ventricle, contains the apex, the pointed part of the heart. So the left ventricle fills up, a lot of the backside of the heart. So we can see there's connective tissue separations between the chambers, between the atria and the ventricles. So this is the atria. There's 2 of the pulmonary veins there on the back side that are coming into the left atrium. And we have electrical activity that causes the heart to contract, which we'll talk about a little later. But the impulse for contraction starts in the atria. So the atria contract first, followed by the ventricles. All right, so going back to our notes then. Looking at blood flow across the surface of the heart. The coronary arteries are the arteries that go over the surface of the heart. We talked about that already. And the coronary cardiac veins receive blood from the heart muscle and take it back to the right atrium, because remember, the right atrium is what receives deoxygenated blood. And the coronary arteries branch off at the base of the aorta, so to make sure that heart muscle receives nice oxygenated blood, there's a little branch off the base of the aorta for that, for those coronary arteries. We have the right coronary artery and the left coronary artery. When there is a clot in the left coronary artery, that's a very serious situation. That's a cause of major heart attacks and sudden death due to heart attack. Maybe you've heard of certain types of heart attacks called the widowmaker. When the left coronary artery has a clot in it, the whole left ventricle is deprived of oxygen and shuts down and can't pump to the body, and a person dies very quickly. So it's very important for people that who are at risk for heart attack that they take their blood pressure medicines and get their cholesterol under control, because a clot in that left coronary artery is deadly. So when we look at some of the procedures for repairing clogged vessels, we have what's called a heart catheterization. And a heart catheterization is when we run a vessel up through the femoral artery and we place a stent inside to open up a clogged vessel. And I do have an animation showing that procedure here. Heart caths are very common procedures performed every day in hospitals around the country. So there's the aorta. Here is the large aorta that branches into the hip region and becomes the femoral artery. So there's a small incision made in the skin and goes into the femoral artery. So it goes up an artery, up all the way up the abdominal aorta, up the thoracic aorta. That's the common vessel that branches down from the aorta. So it travels all the way up to the aorta. And then that start of the coronary artery circulation, it's the tip of the catheter. It's going to shoot a dye into the blood vessels of the coronary circulation, into the coronary arteries, to take a picture, to take an x-ray. So the dye is shot into those vessels, and then we take a picture and look at it. And we can see here the catheter and the vessels over the heart, and we can look for narrowing. So here's blood in this vessel. This would be the left coronary artery. We can see there's a narrowing right here. So depending on how narrow that space is in that artery, we can put a stent, and it looks like a little screen, a little tubular screen that's placed, and here's the plaque buildup that's narrowing that vessel, and they inflate that with a balloon. It pushes that plaque to the side, and then we have better blood flow through that space again, and a person feels a lot better after having a stent placed. Anybody who has a stent placed has to take a blood thinner for the rest of their life because they're at risk for clots because of that stent being placed there. So it's important that people take their blood thinner medication if they have a stent in place. So that's what a heart cath and a stent is. Sometimes people have such a blockage that we can't put a stent and we have to do bypass. So they'll take an artery from the leg, they'll take a vein from the leg, and they will bypass the clogged area. If the blockage is right here, they'll take another vessel and make a bypass and go around that blocked area, taking a vessel from the leg. So that's a very common procedure that's done as well, bypass surgery. It's much more invasive. They have to crack the chest, they have to crack the sternum and actually look at the surface of the heart. So it's an extensive procedure, much more invasive than cardiac catheterization with stent placement. I work on a cardiac floor, so I take care of these patients on a regular basis, and they do have good outcomes for the most part, but people definitely need to exercise and adjust their diet and participate in cardiac rehab to get the full benefits of bypass surgery. If they go back to a sedentary lifestyle and poor eating habits, typically they'll come in and need more bypasses or more stent placements. So smoking has a high risk factor for cardiovascular disease. Smoking causes cholesterol to deposit on the inside of our blood vessels, as well as narrowing of our blood vessels. Nicotine, once it enters our system, is a vasoconstrictor, which means it causes vessels to constrict. So people who smoke during pregnancy have smaller babies because of the vessel constriction that occurs in that umbilical artery and vein, and causes less nutrients and blood supply to go to the baby, so they tend to be smaller in size. And also, again, high blood pressure for the smoker, and cardiovascular disease, blockages, blood clots, strokes, heart attacks, much more common in smokers than non-smokers. And in the patients we see on the floor I work on, lots and lots of patients have been smokers or are active smokers, and the younger they started smoking and the more they smoke, the younger they come in for these procedures, and all highly preventable just by quitting smoking. So looking at the blood flow through the heart, then we see that the atria contract first, then the ventricles contract, and the contraction of the ventricles is called systole. Relaxation is called diastole. So systole, diastole are two terms you should know. Systole means contraction, diastole means relaxation. So whenever we look at blood flow through the heart, the atria contract first, and that sends blood to the ventricles. Then the ventricles contract, and that sends blood to the pulmonary artery and to the aorta. Then the ventricles relax, the pulmonary valve and the aortic valve close, and then the process starts again with the ventricles filling passively at first and then the atria contracting. So most of the ventricles fill by just passive blood returning from the veins to the heart through that muscular contraction we talked about in the last video and the deep breathing that occurs to help blood flow back to the heart. So most of the time, or most of the relaxation phase of the ventricles, the blood is passively filling those ventricles, and then the atria contract and fill up the last 20%. So 80% is passive. So this is a continuous cycle of blood flow coming from the heart and leaving the heart via those contracting and relaxing of those chambers. So what starts the contraction is the SA node, and that's in the right atrium. And when a signal comes from the cells in that SA node, the cells of the atria contract, and that starts the contraction that leads down to the ventricles. So we call the SA node the pacemaker, because that's where the impulse begins to start contraction of the heart. So there's a picture of this electrical system in your textbook. This is the photo from your textbook. This is on page 98. And if we look, we can see the SA node here in the roof of the right atrium. That's where the signal begins for muscle contraction in the atria. And then that passes through to the left atrium very quickly, and the two atria contract together. And then that impulse goes to another node called the AV node, and then it travels down the middle of the heart, and it stops here. It's called the bundle of His before it branches to become the bundle branches, and then it comes up the sides called the Purkinje fiber. So this is all an electrical pathway for this impulse to travel through the heart. So if we look at it, the SA node contracts first, or the atria contracts first with the help of the SA node, then the impulse travels to the AV node, and then down the middle up the Purkinje fibers, and when the Purkinje fibers receive the impulse, the ventricles contract. So the atria both contract together and the ventricles both contract together. So it's a top portion contracting, bottom portions contracting together. The left and right sides contract together. And it has to follow this pathway. And when we see heart arrhythmias, people with abnormal heartbeats, that means something's wrong with this pathway, and that impulse isn't traveling down the path correctly, and there's special beats that occur, or extra beats that occur, or sometimes there's blockages in the pathway due to cell death from heart attacks that cause the impulses not to conduct the impulse correctly. So this pathway is damaged. A very common condition of this is called atrial fibrillation. There's something wrong with the SA node and the atrial pathway, that the atria perform short little quivering contractions and they don't completely empty, and then people start to suffer symptoms of impaired blood flow, and that needs to be treated, because when the atria are not contracting fully, that blood sits in the atria and can cause clotting, and death by stroke or heart attack. So it's very important with anybody who has atrial fibrillation to take a blood thinning medication to make sure that blood doesn't clot and lead to heart attack or stroke. It's a very common cause of death in people with untreated atrial fibrillation. Fibrillations are always weak contractions that slow the blood flow and put us at risk for clots. So we talked about the electrical system. It starts in the SA node, goes to the AV node, down the bundle branches, and up the Purkinje fibers for those ventricles to contract. So very important, anybody that has ventricular fibrillation, those are weak contractions of the ventricles, that's going to cause death very quickly because there's no blood going to the lungs or the body because of those weak quivering contractions. That's where somebody needs an AED, and where they go and get that shock, electrical shock, from a paramedic or EMT, or even just a regular person that knows, where it's located, and it's very simple to operate. Once you turn it on, it tells you what to do. So, and some people have implanted defibrillators to prevent this problem. If they know they have a problem, they can get an implanted defibrillator device underneath the skin to shock the heart if it should not beat properly. So we call this electrical rhythm that happens throughout the heart an ECG, or electrocardiogram. And we see this little impulse here, this wave of impulses, and they represent different things. The P wave means the atria are contracting, and this QRS wave means the ventricles are contracting, and then the T wave means the ventricles are relaxing, and that's the end of my contraction cycle. So we should always see a P wave because the atria contract first to send their blood to the ventricles, followed by a nice, strong, narrow QRS wave, which is the ventricles contracting. And we look at that rhythm when we do an EKG tracing on a patient that comes in with heart conditions or heart problems. So an EKG is an important tool for evaluating the function of the heart. A P wave with a normal QRS is what we like to see, followed by a little T wave showing the ventricles are relaxing. So the atria contracting is the P, QRS are the ventricles contracting, and the T wave are the ventricles relaxing. So this is electrical activity that's occurring down that conduction pathway that we talked about in this picture. So if this conduction pathway is working properly, we're going to see this rhythm when we apply the patches to the surface of the skin over the chest for that complex, for this PQRST complex. This is called an electrocardiogram, and there's a picture of this with a little more information on page 99 of your textbook. So this concludes part 2 of your cardiac unit, and we'll continue in the next video talking about blood pressure.